Hello, everyone. I'm Dr. Enrique Caballero. I am an endocrinologist and investigator, associate professor of medicine at Harvard Medical School, and director of the Latino Diabetes program at the Brigham and Women's Hospital, and chair for the Healthcare Disparities Committee for the American Diabetes Association, and proudly the Boston chapter lead for the National Hispanic Medical Association. And I will be the moderator for this program. Welcome all of you. I know that everybody is busy, but I am sure that you will enjoy the presentations this evening. And you will hear, and I will introduce her now, in particular from Dr. Silvia Rosas, who is a good friend and colleague. She is a nephrologist and investigator. She is also associate professor of medicine at Harvard Medical School and director of the Latino Renal Clinic at the Joslin Diabetes Center, and she is the president-elect of the National Kidney Foundation. And as you can tell, based on the topic and the introduction of Dr. Rosas, we will discuss in particular the important issue of chronic kidney disease in the Latino Hispanic community. So welcome again. And before we start, just very briefly, a few housekeeping items. Please use the Q&A to send your questions to me and to Dr. Rosas. The chat function, the chat box, use it if you have any technical issues. But if it is a content related, an academic question, please use the Q&A box. This program will provide you with CME credits, and the information I will show you in the next slide, but you can also access the nhmamd.org website, and you'll find all the pertinent information there. Your microphones and videos will be off and muted so that there is no interruption during the presentations. But if you want to contact us, as I said, use the Q&A box. This presentation will be recorded and available soon for all of you if you want to review it again. And if you want to share this, the fact that it is available with other colleagues and friends, please, by all means, do so as well. In regards to the CME, as I mentioned before, this program has been accredited for you to get CME credits, one AMA PRA Category 1 credits based on the duration of this program. And as I said earlier, you will be able to claim your certificate at the conclusion of the program, and the information is in the website as well. All right, and with that, I will then go directly into a brief presentation that I have prepared for all of you, which will truly serve as the framework for what Dr. Rosas is going to be talking to all of us tonight. I have been privileged to work with the Hispanic Latino community for a number of years. I have been involved in the fight against healthcare disparities, and I do recognize that even though there's been great progress in this field, there's still a lot of things that we need to do better. So let me just share with you a few things that I think are important as we hear more about chronic kidney disease. And the first thing, well, I have no conflicts of interest related to this presentation, is to remember that obviously you're experts on this. The Hispanic Latino community is the largest community in the United States when we talk about racial ethnic minorities. It's a young population. Most of the population is comprised by US citizens. 4 in 5 have lived here for more than 10 years. And certainly, I think we all agree, is a group with fascinating culture and traditions. There are, however, some socioeconomic and education status challenges that we all need to consider, particularly as we talk about some of the interventions and education pieces that will be discussed later. But the median annual household income, as you can see there, is only $49,000. 1 in 5 living in poverty, 28% of high school graduates, 16% bachelor degree, and 18 without health insurance. That is, of course, an important aspect. Now, from the healthcare perspective, as you well know, unfortunately, our population has higher risk for many different diseases, including diabetes, particularly type 2 diabetes. And these are data from the National Health and Nutrition Examination Survey that show on the left-hand side the total diabetes prevalence. And it's very evident from the beginning to see that the white population has the lowest prevalence, but the so-called racial ethnic minorities, like the Black, the Asian, and the Hispanic community, have twice as high prevalence rates. Now, this is considering also A1C values. So these may be numbers that are a little higher than what you may actually see in other reports, but I truly believe that that is a reflection of what the problems with glucose levels are. Concerning as well is the fact that there are many people with undiagnosed diabetes, as you can see on the right-hand side, particularly in some of these racial ethnic minorities. So more diabetes, many cases that have not been diagnosed with the disease. We also know that the prevalence of diabetes is not the same across all Hispanic subgroups. These are data from the SOL study that you may be familiar with, that has been following different Hispanic subgroups for many years now. And you can see that the prevalence of diabetes differs by Hispanic subgroup, being the lowest in the Cuban and the South American populations and highest in Central Americans, Mexican, Puerto Rican, and Dominican. Now, we don't know for sure whether there are any specific biological factors. Most likely there may be some of the factors that I was discussing earlier regarding socioeconomic, education levels, et cetera, that may impact, of course, lifestyle elements that play a role in the pathophysiology of the disease. But also concerning a concerning issue is not just that there's more diabetes, more complications. I didn't show you the data, but that is the case, and Dr. Rosas will expand on chronic kidney disease in particular. But the other aspect that we're not doing very well on is that we're not achieving treatment targets. And here you see the data, again, from the National Health and Nutrition Examination Survey that has been conducted over different periods of time. And you can see here 3 different periods from 2005 to 2008, which is the darker blue bars across the board, from 2009 to 2012 with the lighter blue ones, and from 2013 to 2016 with the white bars throughout the slide. And what that means is that in these different periods of time, if you look at all these different targets, they have not changed much. Here we have on the left-hand side, the groups by race and ethnicity and what is called blood pressure and cholesterol controlled. In the middle, A, B, C, which is A1C, so that's diabetes control, blood pressure, and cholesterol control. And on the right-hand side, the N is for non-smoking. So the 4 typical targets that we have in our patients with diabetes. And what it's very striking is that the proportion of people, regardless of race and ethnicity, that achieve targets is really very small, but is even lower in Blacks and Hispanics, to less than 20, maybe 15% or less achieve these 4 important targets. So we do have information, knowledge, and the tools to reach these targets, but we're actually not implementing this in clinical practice effectively. And there's obviously many different reasons for that. Now, the other big piece that goes along with this is the issue about the cost of diabetes care. These are data from a study that we did a few years ago with the Medicare population. And what you can see there is the bottom line, 70% of all the money available in the system for diabetes management is spent in only 10% of patients with diabetes. Now, these are the patients with chronic conditions like chronic kidney disease, dialysis, people with cardiovascular disease, strokes, amputations, blindness, all the complications of diabetes. In other words, we're not using the money in any of our healthcare systems for the treatment of diabetes and prevention of complications, but rather the treatment of established complications, something that, of course, is not sustainable. And I was asked a few years ago to write this commentary about what may be happening. Why is it that we're falling so short in achieving targets? And my thought is the following. We all work in a healthcare system. We are the healthcare providers. We talk to patients and try to guide them in order to improve their diabetes healthcare behaviors. And we do that effectively in some, but as I showed you, not in everybody. What is missing? I think that we're not that great, not just on being up to date with everything that is available in the field, but we don't know how to address psychological, social, cultural factors in our patients. That's an area that needs to be further emphasized and explored in routine clinical practice. And I think that we have to accept as healthcare providers that we need to be more humble. We need to learn how to get closer to our patients to be able to provide them with the best guidance on how to improve their self-care behaviors. And that took me also a few years ago to write this paper in which I came up with a list that I call the A to Z list for the management of diabetes that considers different factors, many of which are not addressed routinely in clinical practice. And I will not go through them. You have there the publication that is available for free. And each one of these elements has been documented to be linked to diabetes control one way or another. And there are aspects that we don't address, like depression, acculturation, and we are falling short on nutrition and food availability issues, quality of life, technology, a lot of different things that are very important. And we need to improve the way in which we communicate with patients and we incorporate many of these factors in our routine clinical practice, in addition to all the great scientific information that is available in the field. And this is my last slide, in which I also want to say that we have been very fortunate to learn what is happening in diabetes care with this pandemic. Obviously, it's been a disaster for the world, but there are always lessons that are important to take into consideration. What you can see here is a graph that we created. I was very honored to chair this group of international experts. We discussed the issue about diabetes during the COVID-19 pandemic. And what we found was that in the past, this is the upper left-hand corner, we were just waiting for people to come to us in our clinics or hospitals. And this is the routine care, solving acute problems for our patients and then sending them home and not really knowing much about them. Now with the pandemic here on the left lower side, we have been forced not to see them in the clinic or the hospitals, but to try to reach them when they're in their homes, in their community, either via telemedicine, telephone conversations, etc. And that has worked actually not perfectly well, but better in terms of being more in touch with our patients. And we hope, this is the right upper hand corner here, that as things get better and we get rid of all these threats from this pandemic, that we don't go back to what we were doing before, but in the future, we incorporate the lessons that we have learned from this pandemic and hopefully find a better way to create communications with patients when they're not in the office, where they're not in the clinic, addressing the so-called social determinants of health, which is, of course, of paramount importance in the fight against healthcare disparities. And ultimately, as you can see here on the right lower side, we should be better prepared for future disasters, hopefully not soon, but I think this has been a tough lesson for all of us to learn from. So anyway, I just want to conclude here and just say that obviously the Hispanic Latino community has been affected in many different ways from diabetes and its complications. There's been some progress, but I think there's a lot more that we all can do in order to improve the care and health of many patients and families out there that would benefit from our participation in a more exhaustive way with many of these clinical aspects of care. So I leave you there with my email accounts in case you have any additional question or information. And at this point, I am going to stop sharing so that Dr. Rosas can come on stage and now talk in more specific terms about chronic kidney disease in the Latino Hispanic population. Sylvia, please, you can start your presentation, and welcome to the program.
Great. Thank you, Dr. Caballero. Thank you for the NHMA for inviting me to discuss chronic kidney disease in the Latino Hispanic population. And thank you for the attendees for having an interest. Just want to make sure that everybody can see my slides. So give me a thumbs up.
Yes, we can. Mm-hmm.
Okay, perfect. So these are my disclosures. I may have a couple of similar slides to Dr. Caballero, but I'll quickly go by them once we reach them. This is the last census comparing 2010 to 2018. I'm sorry, 2010 to 2020 census. And you can see that while certain groups stayed the same or shrunk, the Hispanic population continues to grow and grew from 15 to 18% of the population. The Asian population also grew 1%. And the other thing that grew is the individuals that now assign themselves as 2 or more races. So all these people here are Latinos, and you can see that just being Hispanic or Latino, which I'll use interchangeably in the presentation, does not mean that you look a certain way or have a different color. So you can be Latino and be of any race, including Asian, Black, white, whatever. Being Hispanic just means that you have a origin or descendant from Spain or Latin America. And you can see here that we are a mix of basically every race, and what varies is perhaps the proportion by country. So here we have Mexican Americans who may have more of an American, Native American heritage versus perhaps Puerto Rican have a little bit, as a group, a higher percentage of African heritage. And this can be seen here. The previous slide was an older way to present the data. Here, this is each line is an individual person, and you can see in green is the European ancestry, in I don't know, orange is American ancestry, and the purple is African ancestry. And it's basically very similar. Dominican and Puerto Ricans are more likely to have a higher proportion of African ancestry versus people in Mexico, Central America, and South America have a higher proportion of American heritage, meaning American, Native American. I put in this slide to remind everybody that the United States is the 5th largest country with Spanish speakers in the world. So we have more Spanish speakers in the United States than we do, let's say, in Venezuela or Peru or Chile. Argentina is a little bit above us, Colombia. But you know, the way Latinos are growing in the United States, we're pretty sure that we'll probably achieve 2nd or 3rd place soon. So now let's get to chronic kidney disease. So chronic kidney disease, this is the definition from our kidney disease outcomes committee from 2012. And it's chronic kidney disease is an abnormality of kidney structure or function present for greater than 3 months that have implications for health. And chronic kidney disease is classified by the cause, the category of how much you filter blood in your kidney and how much albumin you're spilling in your urine. And you'll see that the G stands for glomerular filtration rate, and it goes from 1 to 5, depending on the number that was used. So greater than 90, 60 to 90, 45 to 60, 30 to 45, 15 to 29, and less than 15. Less than 15 are everybody that was considered kidney failure or on dialysis. And then albumin 1, 2, 3 is also by grade. So less than 30 is considered normal, although 20 is better than 10. I'm sorry, 10 is better than 20 and 20 is better than 30. But moderate proteinuria or albuminuria, sorry, is 30 to 300, and greater than 300 is considered severe albuminuria. And you can notice that the majority of Americans are here in this green section. So that's where you want to be. You'd want to have normal filtration in your kidneys and no albumin in your urine. And then the yellow means you're at increased risk for kidney failure. And then the orange, moderate risk, and the red, you're at very high risk. So those are people that are at very high risk of ending up on dialysis. So when you have very high protein in the urine or very low GFR. So the prevalence of chronic kidney disease in adults has been evaluated. So if you don't have diabetes, your risk is much lower. But the longer you have diabetes, and this is what you are more likely to have diabetes, to have chronic kidney disease. And if you have proteinuria, you're at increased risk of developing kidney failure. This is data from Ann Haynes, and just wanted to show you that here has kind of the same nomenclature that was discussed earlier. The darker blue, let's say, is a white, the mustard color is black, and the light blue is Mexican Americans. Remember, Ann Haynes does not sample for all Hispanics, they only sample for Mexican Americans. So, and Mexican Americans are about 60% of the Hispanics in the United States. And basically you can see that over time, there's perhaps an increase a number of people with diabetes on glucose lowering medication, but you can see that the rate is lower for Hispanics than it is for other races. And the use of ACE inhibitors is very low among everybody. And we'll discuss that in a little bit, but lowest in Hispanics, which are the group of individuals that are at highest risk. And ACE inhibitors are used or standard therapy for diabetic kidney disease. And again, the use of statin over time has increased a little bit, but again, lower in Hispanics than it is in the other groups. And you can see that while A1Cs have improved in the white population, they really have not improved significantly in the Hispanic or even the African-American population. Similar results can be seen for systolic blood pressure and LDL. So why is it important treating chronic kidney disease? Because in this work done by Dr. Afkarian, which is now about 10 years old, she demonstrated that just having diabetes does not increase your mortality. And we can look at model 1 or model 2, they just basically one adjusts for a couple more variables than the other, but you can see that there is no difference, there's no increased risk in mortality. But once you have kidney disease, just kidney disease, not diabetes, your mortality increases by 9%. And if you have diabetes and kidney disease, that mortality adjusted difference is much higher. And the same is true whether you have cardiovascular mortality or you have non-cardiovascular mortality. And why is that? Being on dialysis, it has a 35% survival for 5 years, whether you're a woman or a man. And that survival is worse than most common cancers. So the survival on dialysis is worse than breast cancer or colorectal cancer. And it's perhaps only slightly better than pancreatic or lung cancer. So ending up on dialysis is not what we want for our patients with diabetes. So dialysis should not be a destination. And I will discuss some new therapies that hopefully will prevent that. Having chronic kidney disease, remember, these are the I'm hoping you can see my arrow, but these are the better spots to be on. It not only puts you at risk for ending up with kidney failure, but it also puts you at risk for all-cause mortality, cardiovascular disease, and acute kidney injury. So why do we have this high risk of having kidney disease? And part of it is because there's little awareness that they have chronic kidney disease. And I'll discuss why in a minute, but you can see that part of the problem is that we are not testing for chronic kidney disease. Chronic kidney disease is a silent disease. And here's data from Medicare. These are older individuals, so more than 65. And you can see that yellow is no diabetes, no hypertension. So those people are at low risk for kidney disease. But even those with high risk, the curve green with diabetes or hypertension, diabetes, no hypertension, or hypertension, no diabetes, you can see that only 40% of them, over time, it has increased, but only 40% of them have been tested for kidney disease, because to test for kidney disease, you need two tests, a blood test to test for creatinine and a urine test to test for albumin in the urine. And here is for those individuals that have diabetes and chronic kidney disease, or diabetes and hypertension, or diabetes no hypertension, you can see that, well, the rate of testing for chronic kidney disease is also not much better than our previous slide. Here is a more recent data. This is from about a year or two ago, looking at 27 different health systems. And you can see that only 44% of the people that are at risk, so those that have diabetes, hypertension, cardiovascular disease, a family history of chronic kidney disease or obesity, only 44% of them have an annual test for albumin in their urine. So if you don't test, you'll never find out you have chronic kidney disease. So why is it important? So here's is another representation of, in orange, the prevalence, and in sort of mustard, let's call it, the diagnosis in the chart of chronic kidney disease. So you can see that the prevalence of chronic kidney disease is much higher if you look at the labs than what the physician is putting as a diagnosis. But it's really important to know that, because we know that as chronic kidney disease progresses, as was mentioned previously, the cost for the patient grows because the complications for different things are exponential. And here is a graph of how much dialysis costs. This is one is the month, let's say they were started on dialysis, and you can see what the cost was prior to dialysis. Then once the month they got started on dialysis, that month cost $14,000. And then after that, every month, how expensive it is. So let's talk about how Hispanics relate to their primary care provider. So we know that when they have a good relationship with their primary care provider, this was a group of 252 adults with chronic kidney disease. They all received this ACE questionnaire that basically looks at the patient experience with their provider, and they followed the patients over almost 5 years. They looked at hospitalization, end-stage renal disease, and death, hoping that the better relationship they have with their primary provider would make differences in those three very important outcomes. There was no difference in end-stage renal disease or death, but they did find a significant difference in hospitalizations. So those that have the better experience with their primary care provider were hospitalized lower, so less times. And that was so if you had lower score in this ACE subscale scores, in poor communication, poor trust, poor treatment, you can see that they were 50% more likely to be hospitalized. Again, these are the domains of that ACE. I'm going to skip that in the interest of time. When you work with a Hispanic population in whatever city you're in, you only know that Hispanic population in that city, because depending on where you are, the mix of the people in your city may be different. And that's what I wanted to highlight here. So for example, if you're in Texas or California or Arizona, you're more likely, your Hispanic population is more likely to be Mexican. But if you're in the Northeast, in Connecticut, in Pennsylvania, in New Jersey, even in Boston, where we are, you're more likely to encounter Puerto Rican mix. If you are in Washington, D.C., there's more mix of Central American, particular Salvadorian. And obviously we all know that if you're in Miami, the large percentage of the Hispanics there are Cuban. Important for our note also is that in Boston, that's why I put it here, there's a big group of Dominicans. And why is that important? When we're doing research studies in the Hispanic population, you want to make sure that you capture all of these groups. And that's why this study was mentioned, the Health Community and Health Study, the SOUL study that has these 4 field centers. And this slide you already saw, diabetes and hypertension are the 2 more common risk factors for chronic kidney disease, and they're different by ethnic background. And here's hypertension, which also is different by ethnic background. And that it may explain why certain ethnic backgrounds are also at increased risk for chronic kidney disease. So here's the prevalence of chronic kidney disease. And if you see, compared to white, actually there's less chronic kidney disease stages 1 or 3 in the Black and Hispanic population, but that's because we move faster into end-stage kidney disease. African Americans are 4 times more likely to be on dialysis, and Hispanics are about 2 times more likely to be on dialysis compared to our reference group of white. Our Hispanic population, again, this is using Anheim's data. So again, this is Mexican Americans, but you can see that if your GFR is less than 60, you are almost twice as likely to have albuminuria if you are Mexican American. And this is looking at all the diabetes complications in Kaiser Permanente. And while some are not very different, like amputations are perhaps not very different than whites, things like myocardial infarction are perhaps less often in underrepresented minorities, but end-stage renal disease, you can see, definitely is more likely in Hispanics. So we talked about awareness and how our patients are not aware of the disease. This is using, again, Anheim's data, the National Health and Nutrition Examination Survey. And you can see that from stages 1 to 3, very few patients know that they have kidney disease. And it's only when they reach stage 4, and stage 4 is 15 to 30. So people start dialysis usually between 10 and 15. So it's very late in the disease. And even then, less than 50% know they have chronic kidney disease, which leads to why this is. And part of it is system barriers, and part of it is clinician barriers. Chronic kidney disease is asymptomatic. There's really a gap in clinical knowledge about chronic kidney disease guidelines. There are challenges, the guidance are evolving as we learn more about kidney disease. And so it's hard for a primary care provider to stay up to date on everything. And there's this perception that there's nothing to be done. And so that, I think, leads to this inertia of not doing anything, basically. And there are systemic barriers also, like I think this health system should provide reminders, or this person is at high risk, or did you check an albumin this year? Did you check a creatinine, etc. So there's this limited computer decision support for chronic kidney disease. And also the healthcare system does not allow the time necessary to take care of complex patients. Chronic kidney disease patients are complex patients. We already discussed they have diabetes, they have hypertension, they have cardiovascular disease, they may be smoking, they have low health literacy, etc. So it takes time to take care of a patient like that. And we need more patients, extenders, nurse practitioners, physician assistants to help us take care of these more chronic disease patients. So I wanted to show you the prevalence of diabetes. I'm going to perhaps skip this because Dr. Caballero had talked about it, but these again are the prevalence by subgroups, just showing that by age, the older you are, the more likely you are to develop diabetes. So if you live to be 70, half of all Latinos will have diabetes. And again, the prevalence of diabetes increases by the more obese you are, the more likely you are to have diabetes. And you're protected if you have higher than high school education or your household income is high. So we all know that this really has nothing to do with really education, et cetera, but really has to do with lifestyle factors. Maybe you're able to afford food, you're able to afford a gym, you're able to afford, educational information, et cetera. And so this is about diabetes awareness and A1C control, stratified by age. And as we age, we are more aware of who has diabetes. Very minimal improvement in A1C control, but perhaps there is. And as we age, again, increasing number of patients have insurance, I'm assuming because they are eligible for Medicare. So this is similar data from the SOUL study again, looking at the other risk factor, which is hypertension. And you can see, I'm not going to go over all the numbers, but basically showing you that hypertension control is very poor. Not even half of all Hispanics have, maybe a third have good control. Remember, for chronic kidney disease, we want them to be 130/80 or less. And really, very few of them have that, not even a third. Why is it important to refer to a nephrologist on time? Because studies have shown that there's improved mortality, there's decreased hospitalization, and better patient outcomes with regards to nutrition and anemia if you refer early to a kidney doctor. Unfortunately, about 75% of individuals do not see a kidney doctor. Here's data from 2019. It says that 41% of all dialysis starts never had a kidney care. So basically they showed up to the emergency room, they didn't feel well, they were surprised they had kidney failure, nothing to be done. And this is why primary care providers would be so vital, because we need to raise awareness, start screening so that we can intervene so that this stops happening. I've discussed this already. I wanted to show you this. This is data from MESA, trying to look at those racial subgroups. They looked at 5-year intervals and how much progression there was. This is GFR loss over time. And you can see that Hispanics, compared to whites, have an increased loss of GFR, over annual GFR loss. But you can see that that's driven really by the individuals from the Dominican and Puerto Rican background. And for those of us that live in Boston, I showed you that that is the majority of the population that is in our New England area. Of course, there are other backgrounds too, but we have a very high risk of individuals for a chronic kidney disease. I wanted to show you this because some people say, oh, this is access, problems with access to care, etc. But so this is a nice study because these were all veterans. They're all supposed to follow the same protocol. They all have the same insurance. And here they looked at if they had seen a provider, if they progressed to stage 5, which is the one I told you, kidney failure, or death. And you can see that while death, perhaps very similar, you can see that Blacks and Hispanics in the VA system are referred more often or frequently to the nephrology. Doesn't tell us when. It doesn't tell us, how late in the disease it was, but at least they were referred. But it does show that disparity that we said, that rapid progression to stage 5. And here they're subdividing it further until with the Hispanic white or the Hispanic Black. Again, this is self-reported, but you can see that there was really no difference. The adjusted ratios are the same. This is data also from the CRIC study. looking at Hispanics versus the rest of the CRIC cohort, looking at CKD progression. These CRIC patients are very similar to what we discussed. It's significant, don't have high school degree, they live in poverty. Some, same as was described, 3/4 have health insurance, 25% do not, and half of them have nephrology care. They are less likely to smoke. Hispanics are less likely to smoke, but everything else is higher. They're more likely to have diabetes. They're more likely to have uncontrolled blood pressure, and their A1Cs are higher. Their GFRs are lower. And so what does that lead to? They're the highest group to end up either on end-stage renal disease or lose half of their kidney function. So that rapid progression that has been seen in other cohorts, we also saw in CRIC. But mortality, there is basically no statistical difference. Here, this is the GFR loss that was seen in CRIC. The top line are the non-Hispanic whites, non-Hispanic blacks, and here are the Hispanics. So they're the more rapidly progressors. We don't want to forget the other cardiovascular preventive care management that needs to happen. And here we are having some data about guideline recommended goals for the secondary prevention of cardiovascular disease among the CRIC patients. And you can see that there is differences in, again, the smokers. The Hispanics are less likely to smoke, but then they're less likely to have adequate blood pressure control. They're less likely to have physical activity, or less likely to have adequate weight, adequate A1C control, and really no difference in use of RAS blockade, at least in this cohort. We looked at some genetic factors in kidney disease. There had been some genes. One of them is called ApoL1, and the other one is the sickle cell disease gene that had been associated with chronic kidney disease. So we looked in our cohort to see what that looked like. In this particular cohort of SOUL, about 15% of the whole population has African-American ancestry. In the patients that are from the Caribbean, which would be Puerto Rico, the Dominican Republic, and Cuba, about 25% have African ancestry compared to those that was called mainland, which is Mexico, South America, Central America. Only 6% have African ancestry, similar to what we had described before. And you can see that the people from the Caribbean have decreased GFR more often. They have also more often they have decreased eGFR and albuminuria. And basically, we found that those two genes are associated with who develops albuminuria and who has decreased GFR. But in Hispanics, the risk is not as high. These two genes are associated with a much greater risk in African-American background than they are in Hispanics. So they're less often in Blacks. About 13% of the population has positive for the two risk alleles of ApoL1. And here, only in the Caribbean, only 1% of the population had the gene. So these genes do not explain why Hispanics are at increased risk for progression. Recently, there was a HEDIS measure that was supported by the National Kidney Foundation. It started in 2020 and ongoing in 2021. And this is trying to make sure that in adults with diabetes, ages 18 to 85, there's an annual kidney health evaluation so that they get the urine albumin to creatinine ratio and the creatinine measured. And this is to raise awareness of kidney disease among the physicians and the patients. This is the standard treatment of diabetes. I'm not going to go over it. These are the blood pressure goals, etc. That we, the standard treatment. What I wanted to discuss is when to refer to nephrology. And those are special patients that do not have, for example, diabetic retinopathy, that they're rapidly progressing, that their proteinuria is out of control, more than 300, they have uncontrolled blood pressure. You know, those patients need acute intervention because we want to save those kidneys from getting lost. For about 20 years, as I mentioned before, the standard therapy for diabetic kidney disease included the use of an ACE inhibitor and ARB. Even for a short period of time, there was the double ACE inhibitor and ARB together. We found out that those patients are more likely to get acute kidney injury and have complications such as high potassium. So that's no longer recommended. But ACE inhibitors, what we call RAS blockade, ACE inhibitors or ARBs, are the standard therapy for diabetic kidney disease. And here are the two main studies that have shown why this is important. There was a risk reduction about 16% in this one and about 20% in this one. But now, 20 years later, because remember, these studies were published in 2001, and now more than 20 years later, we find out that RAS blockade, these are different countries, but regardless, very few, not even 60% of the US population, and this is by CKD stage. So this is 3A, 3B, 4, and 5. So even in the best numbers, let's say 60% of the US population that needs the ACE inhibitor or the ARB is on medication. And that does not include the dose, because if you were on any dose, you would count here. So we have not been able to give the medication or the standard medication to our patients, and we need to do better for that. This is a similar study. I'm going to skip that because I want to spend some time on newer therapies. This is an SGLT2 inhibitor. Credence was the first study to have a kidney outcome. We learned a lot from the other cardiovascular outcome studies that perhaps there was a signal for protection of the kidneys with SGLT2 inhibitors. But this study was the first one to be done with kidney outcomes and basically showed that in patients with type 2 diabetes and albuminuria, so they had kidney disease, canagliflozin reduce the risk of both kidney failure and cardiovascular events. That's why we have the two kidneys and the heart here. That reduction was less than 30%. So you need to treat 21 individuals to save a life. And here it was also protective for end-stage kidney disease. So there was a 32% reduction in your risk of developing chronic kidney disease. And then the dapagliflozin study came out, DAPA-CKD, and this is the overall study results. It was also positive. What was different with DAPA-CKD is that a significant number of the patients, about a third or so, did not have diabetes. Maybe even half, I don't remember, a significant number of them didn't have diabetes. So even in those patients that did not have diabetes, SGLT2 inhibitors were protective for kidney disease. So there is a SGLT2 inhibitor, in my opinion, is no longer an anti-glycemic medication, but it's really a kidney disease medication that we need to make sure gets to the people that need it. And here was outcomes, really subgroup analysis to see if there were any difference in which groups benefited or not, but you can see that everything is below 1, meaning that dapagliflozin did better than placebo. Also this year, we learned that, or last year, that finerenone, which is a non-steroidal mineralocorticoid receptor antagonist, also provided protection for those patients with type 2 diabetes and proteinuria, albuminuria. So they also had an 18% reduction in risk for the primary composite outcome of kidney outcome. So also another medication that was positive. And the result of Credence has been repeated again in DAPA-CKD, and other studies that have aggregated their patients. So in addition to those, we are waiting for the outcome for the GLP-1 study that is going to have the kidney outcome, which is called FLOW. But this is the cardiovascular study, and basically showing that there is a signal for reduction in albuminuria here of 22% using GLP-1 inhibitors. And this is the kidney outcome study that was published a couple of years ago. Now, again, that's a 22% reduction here. And here you can see that the majority is because there's a reduction in albuminuria. So now there's plenty of articles out there using different algorithms. If you have proteinuria, if you're high risk for heart failure, if you have cardiovascular disease, it recommends sort of what medications you can use. But the important thing to note is that we always start, this is a KDIGO slide, showing that we always start with lifestyle factors, but now SGLT2 inhibitors and RAS blockade are in equal footing and should be provided to most patients. So how are we doing with SGLT2 inhibitors? So they were first on the market in 2015. And so far we've gone from like 3% to 12%, I don't know, 14%. And you can see that that's not good enough. We have this epidemic. We have 37 million Americans with chronic kidney disease, and we need to make sure that these medications get to the people that need them. I also just wanted to spend a few minutes discussing the recently released GFR estimation equation. So before we had a GFR equation that included age, race, gender, and your creatinine value. Because race is not a biological construct, but a social construct, the National Kidney Foundation and the American Society of Nephrology created a task force that was called the Task Force on Reassessing the Inclusion of Race in Diagnosing Kidney Disease. And a new formula has been adapted or supported, let's say, and it's called the CKD-EPI creatinine refeed equation. So basically it does not have the race variable. Some of the numbers have changed, and we're calling it the CKD-EPI 2021 refeed equation. And you can go to the National Kidney Foundation in the GFR calculator. There's an app for it too that you can download, and that should be the GFR equation that we're hoping that your institutions will use from now on. The second thing is to start using cystatin C more often in those patients that we're trying to define whether they have chronic kidney disease or not. And again, we're looking for increased funding for research in kidney disease. These are some examples. Before, we used to have a blue and a red. We used to have these are, I'm going to go over the man example, but let's say you had a creatinine of 1. If you were here in blue would be if you were non-Black, in red would be if you were Black. There was a 16% increase if you were African American. With the new equation using green, you can see that that inflation is gone. And you can see that as the GFR, as your creatinine worsens or your GFR declines, that bias, the difference has decreased. And you can see that age is still important for your GFR. So as even with the same creatinine of 1, as you age, your GFR declines. That remains the same. So we're very proud that nephrology, there are many medical algorithms that use race, but we're very happy that nephrology, in partnership with our patients and our labs, et cetera, was the first medical specialty to address and eliminate this race-based equation. So in conclusion, I want to end up reminding you that diabetic kidney disease is very common in our population, that we have so many therapies now for chronic kidney disease, for halting progression of chronic kidney disease. So we're very hopeful that in the future, we're going to see hopefully a decline in those patients that have kidney failure, but we will never be able to treat the patients that need it if we do not raise awareness of those individuals that could be at high risk for chronic kidney disease, and we screen them. Because if they don't know they have chronic kidney disease, nothing will happen. And we want to avoid inertia, not only in the management of diabetes, but also in the management of hypertension and lipids and cardiovascular disease. These are complex patients, and every time we see them, we should make sure that their medical management is optimized. I wanted to remind everybody that World Diabetes Day is right around the corner, November 14th. I want to acknowledge my many contributors and funding sources. And this is my contact information if you have any questions. Thank you.
Great. Thank you, Sylvia. That was a very nice, very comprehensive presentation. So at this point, I just want to ask people in the audience, we only have a few minutes, but we can try to address any question if you have any. So please submit them through the Q&A box. In the meantime, Sylvia, I was really fascinated by some of the data that you showed about the prevalence and progression of chronic kidney disease in different Hispanic subgroups. And I was thinking as to, for example, you show that Puerto Ricans and Dominicans, if I remember well, have a higher risk of developing chronic kidney disease, or at least, in the progression data that you showed. And I guess probably there's no easy answer, but I was also reflecting on the fact that, as you also showed, the Black population in general has a high risk for chronic kidney disease. And considering what you also showed about the race, ethnicity background, could it be that the presence of so-called Black genes, perhaps more in Puerto Ricans and Dominicans compared to other groups, could contribute to the higher risk of chronic kidney disease? Is that something that, could you speculate a little bit about whether that could be a factor, or it's more all the other elements, control?
So that's why we looked in our cohort, this APOL1 and sickle cell disease genes, those two genes are more prevalent in, or are prevalent in, more common in people of recent African ancestry. And but we found that Hispanics in general, only those in the Caribbean, only 1% of them have them. And those that have them, it is associated with more proteinuria and decreased GFR, but it does not explain the epidemic of, there might be another gene, but we haven't found it. It's not APOL1 and it's not sickle cell disease.
Okay, great. All right, I don't see any other. Let me just ask you briefly, maybe a couple of questions, and then we can close the program. One is in terms of microalbuminuria, just for everybody in the audience, in case they are considering doing that routinely. Are there any false positives for microalbuminuria? What are the conditions that people need to consider? If they order microalbuminuria and it's slightly elevated, do you need to repeat it? Are there factors that increase the value?
Yeah, so we do repeat it. If it's positive, we repeat it 3 to 6 months later. That's the recommendation. But things that can make it positive are, for example, urinary tract infections. If you're on your period, that type of thing, it does affect your values. But in general, at least the population that I see is a little bit older and doesn't really, as long as you teach them how to get a clean catch, it usually works okay. And I want to say that we recommend for patients with diabetes to measure albumin to creatinine ratio, but I know that not everybody has that available. So if your site only has protein to creatinine, we're going to have to deal with that. But ideally, you should tell your lab that they should have access to albumin to creatinine ratio and not be measuring the dipsticks, because the dipsticks are not adequate.
Yeah. Okay, yeah, I think that plus the GFR that you already covered, I think those are important things. Let me see, there's one question in the chat. I don't see it here. Okay, I see it here now. How can we educate patients on CKD with current medical materials? Do you think that there is enough medical information content in Spanish available to Hispanic Latino patients?
Well, I have to say there's never enough. So I'll start with that. But there are materials. So you can go to the NKDEP, so National Kidney Disease Education Program, and they have materials. They have materials in Spanish and in English on, let's say, low salt diet, how to explain what the GFR is, etc. And also I would recommend the National Kidney Foundation website. They also have content in English and in Spanish that is also very valuable. And the website is www.kidney.org. So very easy to remember. And I think I mentioned during my talk that you can download the GFR app also at, you just put NKF GFR and it will pop up at your app store. And there's also an online link. And to be honest, it's the most commonly used link for the National Kidney Foundation. I think it has like over 1 million hits every year, which is how to calculate the GFR. So there's a online GFR calculator too that you can find. But there is information in Spanish from other sources, and now I'm blocking on some more, but there are, there are good sources out there. And so you don't have to translate things yourself. For example, in our institution, we have to get everything approved by our education department. So sometimes there's a little bit of hurdle with that, to trying to get things approved by others before you can give it to the patient. But you can just tell the patient to go there and they to download it.
Yeah. Okay, great. Excellent. All right. There's one question that just came in from Diego Gomez. Are there any signals on different efficacy on current therapies in Hispanics? Example, time to dialysis, eGFR slope, given that most studies are performed mostly in white subjects. Well, I guess one is related to the course of the disease that you address, but you can emphasize that. And the other one is whether people may respond differently to the therapies that you mentioned, like SGLT2 inhibitors or mineralocorticoid receptor antagonists.
Yeah, so you're right that Hispanics are not the biggest group that participated in these trials. And for the DAPA-CKD, they were mostly Asians and whites. And in Credence, I know that they had more Hispanics because they were in South America and Mexico. They were participants in Credence. So far as we know, there is no difference. They both respond the same way. There's no publication that says one group responds worse or better than the other. But you're right that participation in clinical trials of people at highest risk would be ideal, and that we need to make a concerted effort and join as partners with our patients and their communities in order for them to participate in trials that they find that is important to them. And that's why I feel like there's an increased movement in the research community to involve patients earlier than just at the time of recruitment, earlier in the design and in the goals of the study, in what outcomes we're going to look at, et cetera. Because I think only by really involving the community and the patients that we serve or are interested in, that we'll be able to see the results that we want.
Right. Yeah. And I think that requires, as you said, the effort of really establishing that very good connection and trust, with the patients have in the healthcare system and with providers, participate in research studies, because there's no other way to learn whether these medications may work differently or not, unless we include more of these individuals in the studies. One final question from me, and then we'll close, Sylvia, is all clearly, as you well said, there are new medications like SGLT2 inhibitors, GLP-1 receptor agonists, but SGLT2 clearly for chronic kidney disease. Would you see that the primary care physicians are the ones that could start these therapies, or to refer the patients to the nephrologist so that they are the ones that start these therapies? Because based on the numbers that you say, there's so many patients, and maybe not everybody is going to see a nephrologist. What is your thought on that?
So I agree with you, because there are, like I said, we estimate that there's 37 million Americans with chronic kidney disease, and there's only like 15,000 nephrologists. So we would be seeing patients forever if we're there to prescribe SGLT2 inhibitors. So we do need this partnership with PCPs, where we would see the patients that really need to be seen, those that are at higher risk, those that the diagnosis is unknown, those that may need a kidney biopsy, those that you start the SGLT2 inhibitor and they still have too much proteinuria or something else like that. So there is really no reason why the primary care provider couldn't start any of these new therapies, be it the SGLT2 inhibitor or finerenone or a GLP-1. Hopefully that will come out positive. We don't know, but there's some early hope, let's say, that GLP-1 inhibitors are also, GLP-1 agonists, are also, I'm using too many inhibitors, RAS inhibitors. It's like, I forget the agonist. But anyway, that those also will be positive, but we don't know yet. Or maybe, we're so in this high of every recent kidney trial is positive that we're like, can't imagine a negative study, but maybe, we have to wait and see.
Yeah, no, that's great. And it's just a reminder to everyone, obviously, it's important to get familiar with the efficacy data, with the side effects. The education component is absolutely crucial as we discuss all these opportunities with patients. But it requires a comprehensive effort, not to forget lifestyle modification that is always important in addition to the pharmacological interventions. Sylvia, 30 seconds to a minute to close with your final message to the audience, either something that you want to emphasize or that you didn't say that you want people to remember as part of this wonderful symposium and presentation. Sylvia?
I think the most important message that I want the audience to remember is that we have to screen for chronic kidney disease with both the urine test, the albuminuria, and the creatinine to measure their GFR, and make the patient aware that they have chronic kidney disease, because having chronic kidney disease is a risk factor for cardiovascular disease and for mortality. Our patients will die of cardiovascular disease before they reach dialysis. So it's very important to identify these patients so that we can actually treat them.
Excellent. Thank you so much, Sylvia. Well, thank you very much for joining us, for being our panelist, main presenter in this NHMA presentation organized by the Boston chapter. It was fantastic, Sylvia. Thank you very much for being with us. And just as a reminder to everyone in the audience, you can see that slide. If you have any questions, you can contact NHMA. You see the websites there. Don't miss the annual health conference that will be held in March from the 24th to the 27th. And obviously, it would be great if you are not a member to become a member of the organization. And I think there's one last slide here. There's also a very important campaign to end HIV. So if you want to become an advocate for ending HIV, please consider that. You can get more information in the website. You can see there at the bottom. If you want to sign up, I think that's an important effort for everyone in the community. And with that, I just want to thank all of you. I know we went a little bit above the time, but I thought it was fantastic. I think it was really a lot of great information that was presented to all of you. And Dr. Rosas, I think, did a fantastic job in giving you some of the practical things to consider with chronic kidney disease in the Latino Hispanic community. So with that, thank you all. Remember to get your CME credits. You can go to the website. And share this. I think if people didn't have the opportunity to watch this presentation, tell your friends and colleagues this will be available for some time in the NHMA website. So I want to thank, obviously, the National Hispanic Medical Association for the opportunity, for Dr. Rosas and for me to be here with all of you this evening, for everyone that does a great job behind the scenes that you don't see, but they work hard in putting these things together. And thank you all for taking the time for being with us tonight. Have a great night and hope to see you again soon. Thank you, Sylvia.